Hello, my name is Dr. Philip Meese from Seattle, Washington, and I would like to welcome you to the fifth seminar in the Global Education Virtual Seminars being presented by a collaboration between the organizations GRAPPA and Spartan. We're going to be focusing on treatment of psoriatic arthritis, psoriasis, and axial spondyloarthritis in this seminar. This has been a very good series of sessions that we have been having on all aspects of these important conditions. The other thing that has been going on besides the teaching of content about things such as disease manifestations, classification, epidemiology, pathophysiology, and so forth, is to hear from the voices of patients who have the disease. There's a group of patient research partners that are affiliated with the GRAPPA organization who have been invaluable partners for us. GRAPPA, as you know, is an international organization in which there is a collaboration between dermatologists and rheumatologists around the world. And we support not only education, but also research and other investigation into the diseases of psoriatic arthritis and psoriasis. Spartan is an organization focused mainly in the United States, but North America in general, which looks at axial spondyloarthritis both from an educational as well as research point of view. We encourage you to interact as much as possible with us through the chat and the interactive session that we will be having between the various presentations today, as well as in the question and answer period at the end of the session. We will be encouraging you to participate as well with a particular question, which we'll be wanting your opinion about. We would like very much to thank Pfizer for this unrestricted educational grant that allows these seminars to occur. Now, if we can take a look at the next slide, here is the agenda. After this welcoming introduction, you'll hear presentations on psoriatic arthritis by Will Tillett and myself. Will is from Bath, UK, and I, as you know, I'm from Seattle, and we'll be joined by Rodrigo Firmino, who is a patient research partner from South America that's part of GRAPPA. Following that, there will be a presentation on psoriasis by Laura Savage, and following that, a brief panel discussion. Then Michael Ward from the NIH in the United States will be presenting on the treatment of axial spondyloarthritis, followed by a panel discussion and a live moderated chat with all of the panelists. Here are our disclosures. And next. Here is the first question. For a patient with active peripheral psoriatic arthritis, 15 tender and 10 swollen joints, so quite active, and severe skin psoriasis with a PASI score of greater than 10, resistant to conventional synthetic DMARD therapy such as methotrexate, requiring treatment, including either a biological or targeted synthetic disease-modifying drug, which treatment would you select first? A TNF inhibitor, a monoclonal TNF inhibitor, PDE4 inhibitor, also known as apremilast, an IL-17 inhibitor, an IL-12/23 inhibitor, an IL-23p19 inhibitor, or a JAK inhibitor. Please choose Okay, it looks as though the majority of you would choose an IL-17 inhibitor, and then a certain number of you would also choose a TNF inhibitor, and then 10% an IL-23 inhibitor, which is the most recently approved drug, P19 IL-23. And we're going to see some data on all of these. So let's go on into the first presentation. Thank you.
Hello, my name is William Tillett, and together with Professor Philip Mees, I'll be talking to you today about psoriatic arthritis, new therapies in development. I'll start by reviewing treatment paradigms and targets, together with new data on conventional DMARDs, anti-TNF, IL-17 and 12-23, before Professor Mees takes over and examines IL-23, targeted synthetic DMARDs and treatment recommendations. So what's new in psoriatic arthritis? We only had a couple of conventional synthetic disease-modifying drugs at the turn of the millennium, and now we have a plethora of highly effective biologic and targeted synthetic drugs. First, I'd like to talk about treatment strategy, and this is the TICOPA study that you'll be well familiar with by now. Patients with early psoriatic arthritis were randomized to either standard care or a tight control arm, and in the tight control arm, treatment was escalated until minimal disease activity, or MDA, was achieved, and the primary endpoint was the proportion of patients achieving ACR 20. And you'll see here that in the grey bars, the people who were in the tight control arm had higher rates of achieving ACR 20, ACR 50, and indeed ACR 70. So this study showed us that tight control and escalation of treatment until MDA was achieved improved outcomes. The next study I'd like to talk about is the control study, which I think has some real useful messages for our clinical practice. This study examined people with early active psoriatic arthritis who'd not achieved remission on methotrexate monotherapy. The first phase of the study examined the difference between dose escalation of methotrexate versus the addition of adalimumab, and the second phase of the study examined either the addition of adalimumab or the intensification to weekly adalimumab in non-responders. This is the results from part 1, and if I could draw your attention to the figure on the left, you'll see here 42% of patients who had adalimumab added achieved minimal disease activity at week 16, versus only a very small proportion, 13%, in the methotrexate dose escalation arm. The figure on the right shows that trajectory of response, which I always find helpful. This is part 2, and I'd like to focus here on the adalimumab non-responders. 63 of these patients were then escalated to weekly adalimumab dosing, and 30% of them achieved MDA by week 32, providing us some evidence that increasing the frequency of adalimumab injections can be a benefit to our patients with psoriatic arthritis. The next study that I think is useful to our clinical practice is the SEAM-PsA study, and this examined patients with early psoriatic arthritis and randomized to either methotrexate, etanercept, or etanercept and methotrexate. I'm using the MDA here for consistency across the studies, but this was a key ranked secondary endpoint. You'll see that 36% of patients in the etanercept arms achieved minimal disease activity at week 24 versus only 23% in the methotrexate arm. What I think is interesting in this study is that methotrexate doesn't appear to add any additional efficacy benefit to the etanercept arm. So if the SEAM-PsA study told us that the addition of methotrexate isn't required for effectiveness, is it required for persistence with therapy? This study suggests that there may be a role for that in a combined registry of 5 European cohorts, showing that in all but one database, the addition of a conventional DMARD improved drug survival. By example, in the Bath cohort, the median survival on monotherapy alone was 3.2 years versus 6.1 in the group who had a conventional synthetic DMARD co-prescribed. So we've now started to get head-to-head studies in psoriatic arthritis, which is very exciting, and this is the SPIRIT head-to-head study. This examined adalimumab versus ixekizumab, and the primary endpoint was the simultaneous achievement of ACR 50 and PASI 100. And you'll see here that IL-17 was statistically more likely to achieve this endpoint than adalimumab, sustained out to week 52. We've also had trials looking at axial psoriatic arthritis, and this is data from the Maximise trial examining secukinumab 300 and 150 milligrams versus placebo. The key endpoint here is the ASAS20, and the two figures you're looking at on the right-hand side are ASAS20 and ASAS40, and you'll see superiority versus placebo in both the secukinumab doses. We also have bimekizumab, a monoclonal antibody that selectively neutralizes IL-17A and IL-17F. This is results from a phase 2b dose ranging study, and you'll see we're examining 16 milligrams of bimekizumab, 160 plus a loading dose, and 320. And here in figures B, C, and D, you're looking at the ACR20, ACR50, and ACR70 responses, showing promising results, and I look forward to the phase 3 data. Moving on from IL-17, I'd like to talk a little bit about IL-12/23, and here we're looking at the Eclipse study, which was a pragmatic open-label randomized controlled trial, examining the difference in skin, joint, and enthesitis responses to these two mechanisms of action. You'll see here that the tender and swollen joint counts in figures D and E showed similar responses between ustekinumab and anti-TNF, but superior responses in the ustekinumab arm when it came to the PASI response in figure F and the enthesitis outcomes in figures A and B. So any conversation around efficacy also has to consider safety, and as part of the 2019 updated EULAR guidelines, a further literature review on the safety signals was undertaken, and I'm pleased to say that there were no new safety signals in terms of anti-TNF and conventional DMARDs with respect to infections, cardiovascular events, malignancies, infusion reactions, or multiple sclerosis. There are a couple of additional interesting analyses that I'd like to draw your attention to. From the ARTIS and DAM-BIO registries, there was no noted increased cancer risk. From a large UK database, there was an interesting analysis looking at cardiovascular events, and whilst rates were higher in patients with psoriatic arthritis not on DMARDs, patients on DMARDs with psoriatic arthritis didn't appear to show a higher rate of cardiovascular events, building the story that well-controlled inflammation probably improves cardiovascular outcome. The SPIRIT head-to-head study, which I've already shown you, also gives us an opportunity to examine the safety in a randomized controlled trial setting between anti-TNF and IL-17. Here you're looking at treatment emergent adverse events, and you'll see very similar numeric and percentage rates of treatment emergent adverse events. There were no deaths in either arm of the SPIRIT head-to-head study. In terms of adverse events of special interest, you'll see similar levels of infections, a slightly higher rate of inflammatory bowel disease in the ixekizumab arm, as might be expected. To summarise, I've reviewed the treat-to-target strategy in psoriatic arthritis using MDA as the target. We've reviewed the use of conventional DMARDs, particularly with data from the SEAM-PSA and control trials. And then we've looked at the relative efficacy of IL-17 and anti-TNF for skin, joint, and axial disease. I'd like to hand over now to Professor Philip Mees.
Thank you, Dr. Tillett. I am Philip Mees from Seattle, Washington. These are my disclosures. I'll be covering further classes of PSA therapeutics. First, IL-12/23 inhibition with ustekinumab, targeting the P40 subunit of IL-12 and 23, thus inhibiting both cytokines. Here are data from the Summit 1 trial, phase 3, showing ACR 20, 50, and 70 responses, with the light blue being the customary dose of 45 milligrams. Here is data on enthesitis improvement with this drug. Moving on to the IL-23 inhibitor class, these are newer. Guselkumab attaches to the P19 subunit of IL-23 and thus is very specific for that cytokine. Here we're seeing significant improvement in ACR20 response at 24 weeks, as well as improvement in the SHARP score in the every 4-week dose arm, but not in the every 8-week dose arm. Also, improvement of dactylitis and enthesitis. Skin response is very high, as shown here with PASI 100 in slightly less than 50% of patients. One area of focus with this class of medicine has been effect on the spine. There was a failed trial with another P19 IL-23 inhibitor, risankizumab, in a small trial in ankylosing spondylitis, and also a failed trial with ustekinumab. And thus there were some theories about why this might occur immunobiologically, even though IL-23 is considered upstream from IL-17, which does work in the spine. To test whether or not axial PSA might be enough different from axial SPA, in the phase 3 guselkumab program, the investigators identified patients who they thought had axial PSA and furthermore had imaging confirmed sacroiliitis. These are the characteristics of the population, showing elevated VASTI scores at baseline, and about 25% were HLA-B27 positive, consistent with an AX-PSA population. These are the results showing symptomatic improvement, including in the question number 2, spinal pain. Also, some higher threshold improvements of the ASDAS score, such as inactive disease. Thus, we might consider whether there are enough differences between axial PSA and axial SPA to warrant thinking that IL-23 might work in PSA spondylitis patients. To further test this, there will be a study of guselkumab specifically in AX-PSA patients, including an MRI confirmation of spondylitis at baseline and along the way. Here is data on risankizumab, which is being presented in phase 3 at the upcoming EULAR meeting, showing improvements in arthritis and skin responses, as well as inhibition of structural damage progression. And here's data with tildrakizumab showing again improvement of arthritis, and not shown here, but very good results in the skin and other measures. So this is a promising class. Overall, there is very low risk for serious infection, and we haven't seen a signal for opportunistic infection, malignancy, MACE, thromboembolism, or inflammatory bowel disease. Moving on to the oral medications, these work by decreasing intracellular signaling by pro-inflammatory cytokines on an immune cell. In purple in the middle, showing PDE4 inhibition, resulting in increased cyclic AMP and not as much conversion to AMP, thus decreasing pro-inflammatory status of a cell. And on the right, the JAK signaling pathway. Here is data with apremilast ACR 2050 and 70 responses in dark blue, modest effect. Here is data on enthesitis and dactylitis showing improvement, and skin effect, which again is modest, 40.9 PASI 75. This drug is particularly good for patients with modest disease and patients who are safety conscious. There is no signal for serious infection, malignancy, or major adverse cardiovascular events, and no laboratory monitoring, for example, of liver tests is needed. There are tolerability issues during the initial period of use, such as nausea, diarrhea, and headache, and there's an advisement about depression and weight loss. The Janus kinase family of inhibitors will target JAK1, 2, 3, or TYK2, and these various pairs sit at the cellular receptor for a variety of potentially pro-inflammatory cytokines and inhibit their activation of cells. In red are depicted the cytokines that are directly inhibited by JAK inhibitors, and in blue, those that are indirectly inhibiting, including IL-17 and TNF. Here is data from the OPAL-BROADEN study of tofacitinib, and the 5 milligram twice a day dose is approved. It's in the light teal. And also this showed improvement in function and skin response. Here's data with filgotinib, a more selective JAK1 inhibitor, showing improvement again in arthritis, psoriasis, enthesitis, and about a quarter of patients achieving minimal disease activity. Here is data with upadacitinib, again a fairly selective JAK1 inhibitor predominantly, and showing very good ACR responses, skin responses, resolution of enthesitis and dactylitis in a bio-naive population. Note that the 15 milligram dose is what will be approved in psoriatic arthritis come July, and it's in the lighter green color. Here we're seeing data on achievement of minimal disease activity in about a third of patients, improvement of function, and inhibition of structural damage progression. A newer drug, deucravacitinib, is very specific for TYK2. And we're seeing here good ACR responses. And this drug also has very good results in skin response, as shown in the lower left of this slide, as well as improvement of function, enthesitis, and achievement of minimal disease activity. The JAK family in general carries risk of serious infection, herpes zoster, and lymphoma, and one needs to monitor LFTs, CBC, and lipids. It's not clear if the above will apply to the TYK2 specific agents. And a recent trial, oral surveillance in a large number of patients with rheumatoid arthritis who had high cardiovascular risk, was studied and showed increased thromboembolism in the 10 milligram BID dose, so we avoid that dose. It's not approved anyway in psoriatic arthritis. And there was a slight increased risk for MACE and malignancy compared to comparator. This latter data has not yet been fully published, but it is present as an advisement. Treatment recommendations come from several groups. The GRAPPA group last published at the beginning of 2016. Laura Coates will be presenting an update this EULAR and hopefully soon the publication, which will update and include some of the newer medications that we've been referring to. This focuses on the different clinical domains and the efficacy of various drugs. So for example, with peripheral arthritis, it's certainly legitimate to use CSD-MARDs, as well as biologics in the early stages. For axial disease, where there isn't evidence for CSD-MARD effectiveness, we would start with nonsteroidals and then go right to a biologic, and so on. The GRAPPA group also focused on comorbidities as contextual factors for choice of medications. For example, if a patient has obesity and fatty liver, then one might be cautious about use of methotrexate in case there is added hepatotoxicity. The ACR National Psoriasis Foundation came out with a novel suggestion of using a TNF inhibitor first before methotrexate based on efficacy and safety, followed by other agents such as IL-17 inhibitors, IL-12/23, and JAK inhibitors. The most recent have been the update of the EULAR recommendations, and they recommend use of a CSD-MARD initially, but then moving on rather quickly if the patient is not having adequate response to a biologic, including TNF inhibitor, IL-17, IL-12/23. The P19 IL-23s were not yet available in terms of evidence for their consideration. There's slightly different recommendations for oligoarticular patients, and then for enthesitis and axial disease, recommendation to go right on to a first-line biologic. And then, of course, depending on the patient response and patient then considering switching to various other medications that are now approved. Very much to Bill Tillett for that, and now we go on to post question of the same question we asked before. For a patient with active peripheral psoriatic arthritis and severe skin psoriasis resistant to CSD MARDs, what treatment would you select as the first line? And I should note that there is no absolutely correct answer here, and we're very curious about your preferences, but also whether or not there's been any adjustment based on what you've just been listening to. So if you could answer this question. Okay, now let's take a look. So interesting. A little bit more in the way there's a split. For example, in the last previously 25% said just a TNF inhibitor, but now a few more are suggesting monoclonal TNF inhibitor. I suspect that's because of the severe skin psoriasis of PASI greater than 10. And we do have learned that the monoclonal construct TNF inhibitors do a slightly better job in treating skin disease than the soluble receptor, etanercept. We're seeing slightly over a half choosing an IL-17 inhibitor. We certainly know that this class of medication will work very well in the skin. We just saw some head-to-head data that Dr. Tillett presented showing that it was similarly efficacious to adalimumab. And then we are seeing a little bit more in the way of use of the other, the IL-23 predominant inhibitors here, as well as the JAK inhibition. So we're seeing a spread, and I think this is going to depend a lot on a variety of factors, including access to the various medications in wherever you're living. So let's open up here, and I would here is what Dr. Tillett would have chosen, an IL-17 inhibitor. Okay, good. If we could open up now, I'd appreciate if we could have Rodrigo step in. And Rodrigo, if you could introduce yourself and your background and how you became engaged with GRAPPA, and some of your own perspectives about your treatment paradigms. We'd love to hear from you.
Thank you, Philip. Hi, everyone. Well, I'm a PRP from Brazil. I joined GRAPPA, I think, back in 2016. Been participating with other PRPs with discussions in the annual meetings and other programs and projects within GRAPPA. I was diagnosed with psoriasis first in the early 2000s, and then psoriatic arthritis took a long time for me to be diagnosed in the first decade of the year 2000s. And of course, as patients, we feel very excited with the possibilities influenced by, as Dr. Till presented, a plethora of options in terms of new biological treatment, for example, since the early 2000s. I feel very fortunate to be living in what seems to be this new era for patients with PSA and psoriasis. And it seems to be looking good from a medical scientific point of view. However, as patients, we always discuss, and we do have a lot of question marks in our heads, especially if we think of ordinary patients who do not have the same privilege we have for receiving, first-hand information as we do as PRPs. So we usually have lots of questions regarding the relationship between doctors and new drugs, the decision to use the new drugs. The presentation was very enlightening in this respect.
Did you run into any particular issues along the way Have you gone through multiple treatments yet? Because that's what, as a person who sees lots of patients who've been around the block many times, I'm frequently in the position of figuring out the fourth or fifth or sixth medication for a patient. And I'm curious about some of your journey.
Well, first, as I said, it took a long time for me to be diagnosed with psoriatic arthritis. I didn't know about the disease. I was seen by orthopedics, and then until the point that I reached the rheumatologist, and then I mentioned by chance that I had psoriasis. After a few tests, I was first diagnosed with gout until the third doctor probably realized that I had psoriatic arthritis, and started treatment with DMARDs, and it took a long time, not any kind of efficiency and efficacy in the treatment. I was only getting worse and worse until I went to the internet to look for trials, to offer myself for trials, and then I found my current doctor, who happened to know lots of new treatments with biologicals, and we had an appointment, and then I started taking biological drugs, and I'm in the third different medication now, but they seem to be very effective in my case.
Good. And do you have a sense that, as Dr. Tillett emphasized, that there's some sense in the rheumatologist's mind about trying to keep you in a state of minimal disease activity, if possible?
Totally, yes. We always discuss what this represents for me, and yes, it seems to be a target.
Okay. I'm going to then ask that we have a few questions in the chat, but I'm going to save those because some of them are going to be influenced by what we hear about psoriasis and axial spondyloarthritis. And Laura, just a clue to you, we've got two questions about bimekizumab and candidiasis. So I'm going to be curious about in the next few breaks what your comments are on that. But let's, if we could proceed on into Laura's presentation, that would be great. Here we have the pre-question first. So this is a patient with psoriasis, very severe, 22.5 PASI, wow, and obese, not surprising, nail psoriasis, and possible Achilles enthesitis resistant to systemic immunosuppressants, meaning they've tried medicines such as methotrexate or cyclosporin and are still very active. So the question is, which of these treatments would you choose first? So go to it in terms of making a choice. Okay, so it appears that, there's quite a spread. Interesting. Lots of different choices. So it looks as though the group would favor, interestingly, an IL-17 and A inhibitor, presumably partly because of the severity of the psoriasis. And right up there is an IL-23 P19 inhibitor. And we also know that the data from this class of medications is extremely good in the skin. Some small percentage of you would choose an IL-17 receptor antagonist, which I find quite interesting. This is available in Europe, but not as available in the US, brodalumab. So we'll hear a little bit from Laura about that, as well as the IL-12/23 inhibitor, ustekinumab, and 10% a TNF inhibitor. So quite a spread. Laura, it'll be fun for you to comment on this after the next session. So please proceed with Laura's lecture. Thanks.
Hello, I'm Dr. Laura Savage, and today I'll be talking to you about treatments for psoriasis, including new therapies in development. The therapeutic paradigms for psoriasis are constantly changing as a result of the development of novel oral small molecules and biologic therapies, although despite recent advances, the basic principles of a stepwise approach to management remain unchanged. All patients will, at some stage, have used and continue to need to use topical medicaments, and then those with widespread or recalcitrant disease will then need to progress to secondary care for phototherapy, systemic immunosuppressive therapy, or biologic therapy, depending on their disease phenotype. Topical treatments have remained unchanged for decades, and patients often rely on a combination of treatments to reduce both the cell turnover and inflammation that characterise psoriatic plaques. There are several well-characterised barriers to the success of topical therapy, being that patients are often not prescribed enough or advised as to the quantities required, and they may struggle to apply the treatment to inaccessible or hair-bearing areas, and many dislike the preparations that they're prescribed. So considering patient preference and cosmetic acceptability can contribute significantly to compliance. And care must be taken when treating the flexural or genital regions due to the greater vulnerability to steroid atrophy, and calcineurin inhibitors have offered an effective alternative to topical corticosteroids with a more favourable side effect profile. Scalp disease can cause significant psychosocial morbidity for patients, and the addition of agents such as salicylic acid and coconut oil to soften and lift scale should be offered alongside corticosteroids and coal tar to reduce inflammation. Again, considering the preferences of each individual patient in formulation choice and the provision of clear instructions for use is paramount. And there's a continued need for more effective and better tolerated agents with novel mechanisms of action to both improve patient outcomes and adherence. However, the topical management of psoriatic skin is challenging due to the heterogeneity of skin lesions, with some areas being thickened whilst others having a markedly thinned epidermis, and this results in variability in drug permeation and systemic absorption. And drug concentrations may also be reduced due to pre-systemic metabolism of the drug on the skin. So liposomes, microemulsions, solid lipid nanoparticles, nanostructured lipid carriers and micelles have the potential to encapsulate anti-psoriatic drugs for topical application and remain in the research spotlight, alongside techniques such as iontophoresis and lasers to enhance the penetration of the stratum corneum. The majority of investigational topical agents for psoriasis now target the small molecules that modulate pro-inflammatory cytokines and inhibit intracellular signalling pathways, such as phosphodiesterase 4, integrin, Janus kinase, and tyrosine kinase. At the recent American Academy of Dermatology VMX meeting last month, data was presented for roflumilast 0.3% foam, a phosphodiesterase 4 inhibitor, in addition to tapinarof 1% cream, which modulates RL hydrocarbon receptors, and the results appeared promising. Nail psoriasis remains problematic to manage outside the context of biologic therapy, with limited success from topical and procedural therapies. Most phase 3 clinical trials only report nail outcomes as secondary endpoint measures, but until recently there have been no real means of comparing efficacy. Christian Reich and colleagues have taken steps to address this in a recent network meta-analysis of biologic therapies in nail psoriasis, and have convincingly identified those medications targeting interleukin-17 as more effective in achieving complete resolution of nail disease than those targeting IL-23 or TNF. Little too has changed in terms of phototherapy. As a consequence of the pandemic, there has been an upsurge in the use of home phototherapy units, as patients have been kept out of offices and hospitals. There have been a few studies to assess the efficacy and the cost effectiveness, such as the Pluto study, which confirmed that it was comparable on both counts to that given in office. Now, there have been no new additions to our non-biologic armamentarium since the introduction of apremilast in 2014 and dimethyl fumarate in 2018. Fumarates have been popular in Germany for many years and traditionally used in the form of fumaric acid esters until one of the methyl esters was licensed under the name of Skilarence. Efficacy was initially assessed in the Bridge trial against placebo and fumaric acid esters, and PASI 75 rates were reported at around 40% for both active drugs. Apremilast targets phosphodiesterase 4 and was evaluated in patients with moderate to severe psoriasis in the ESTEEM 1 and 2 trials. PASI 75 responses in ESTEEM 2 at week 16 were low at 28.8%, and as such Amgen have subsequently gone on to evaluate apremilast as a potential therapeutic option for patients with mild to moderate disease. And as reported in the ADVANCE clinical trial at the recent AAD meeting, it achieved its primary endpoint of a statistically significant improvement in static physician's global assessment response at week 16 compared to placebo at 21.6% versus 4.1% respectively. The adverse events in the trial were consistent in the known safety profile of apremilast, including diarrhea in 14%, headache in 13%, and nausea in 13%. And at the AAD, we also heard for the first time the phase 3 data for deucravacitinib, the first oral selective TYK2 inhibitor, which forms part of the JAK-STAT pathway. So the POETIC PSO1 and POETIC PSO2 trials, which evaluated deucravacitinib 6 mg once daily against apremilast 30 mg once daily and also placebo, met both co-primary endpoints versus placebo, with significantly more patients achieving PASI 75 and a static physician's global assessment score of 0 or 1 after 16 weeks of treatment. At week 16, 58.7% and 53.6% of patients receiving deucravacitinib achieved PASI 75, respectively, versus 12.7% and 9.4% receiving placebo, and 35.1% and 40.2% receiving apremilast. And amongst patients who achieved PASI 75 response at week 24 with deucravacitinib and continued treatment, 82.5% and 81.4% respectively maintained PASI 75 response at week 52. So moving on now to think about the biologic therapies. Well, we now have 11 licensed originator biologics for psoriasis plus biosimilars, broadly spread across 5 main mechanisms of action. And while there are more treatments to come, it seems that we really have found the sweet spot in psoriasis in targeting the Th17 axis. Aside from deucravacitinib, there are no new cytokine or intracellular targets, and indeed the 2 pipeline therapies in phase 3 trials were for mirikizumab, an IL-23p19 inhibitor, and bimekizumab, which targets the A and F isoforms of IL-17. So the astute amongst you may have noticed that mirikizumab is in grey on my slide. And that's because, despite demonstrating high efficacy in published phase 2 trials, as shown here, and outperforming secukinumab in phase 3 trials, Lilly last month decided not to enter into the crowded IL-23p19 space for psoriasis, and instead are going to focus on IBD. For children, our options are more limited, although we now have 5 biologics with a paediatric indication, the latest being secukinumab, which is approved for children aged 6 and above. Now, compared to our counterparts in rheumatology, we are in a relatively advantageous position as we have many more active comparator or head-to-head clinical trials between different biologics, which can really help enhance our understanding of the differences in treatment efficacy and tolerability. In recent years, novel therapies have moved away from comparisons with TNF inhibitors such as etanercept, and we now have head-to-head comparisons between some of the most efficacious drugs on the market. Now, the first of such trials was the ECLIPSE trial, comparing the efficacy of guselkumab to secukinumab. The time to achieve PASI 90 was faster for secukinumab, but over 48 weeks, guselkumab had a higher PASI 90 response at 84.5% compared to secukinumab at 70%. Another IL-23p19 inhibitor, risankizumab, also went head-to-head against secukinumab as part of their extensive phase 3 trial program. And again, we can see that out to week 52, risankizumab was superior at achieving PASI 90 at 87% compared to secukinumab at 57%. And then a third and final IL-17 IL-23 trial is IXORA-R, comparing ixekizumab to guselkumab, but this time with a PASI 100 primary endpoint at 12 weeks. So unsurprisingly, ixekizumab was superior, although the discrepancy reduced by week 24 when the study ended. And it would have been more meaningful, I think, to see the responses out to at least 1 year, given the chronicity of psoriasis. So the comparative efficacy of biologics in psoriasis has been compared in several network meta-analyses, but one of the most recent and therefore up to date was presented by April Armstrong and colleagues at last month's AAD Congress. A targeted literature review was conducted to identify the most recent phase 2, 3 and 4 randomised controlled trials for FDA and EMA licensed treatments for moderate to severe psoriasis that were available before the 1st of July 2020. PASI 75, 90 and 100 response rates at the end of the primary response period, which was between 10 and 16 weeks from baseline, and the maintenance period, which was between 48 and 52 weeks from baseline, were estimated using Bayesian statistics. And in the short term, across 69 randomised controlled trials, the PASI 90 rates were highest for ixekizumab, risankizumab and brodalumab, each at 72%, which was significantly higher than the remaining biologics and oral small molecules, which are presented here as the number needed to treat relative to placebo. In the longer term, across 11 randomised controlled trials, the PASI 90 rate was highest for risankizumab at 85%, which was significantly higher than brodalumab, guselkumab, ixekizumab, secukinumab, ustekinumab, adalimumab and etanercept. As mentioned earlier, the newest biologic agent that is preparing to come to market shortly is bimekizumab, an IL-17 inhibitor, which is the first to target both the A and F isoform of IL-17. The drug has been investigated in 4 placebo-controlled phase 3 randomised controlled trials, 3 of which had an active comparator arm. In Be Ready, as shown here, patients were randomised 4-1 to bimekizumab 320 mg every 4 weeks or placebo. And at week 16, patients in the bimekizumab arm who had achieved a PASI 90 or greater response from baseline were re-randomised 1-1-1 to receive bimekizumab 320 mg every 4 weeks, bimekizumab 320 mg every 8 weeks, or placebo out to week 56. Patients in the initial placebo arm, or those in the bimekizumab arm who did not achieve PASI 90, received bimekizumab 320 mg 4 weekly out to week 56. And then patients were then subsequently enrolled into an open-label extension study called Be Bright, which is yet to report. So the co-primary endpoint of superiority of bimekizumab 320 mg administered every 4 weeks over placebo was achieved, with 90.8% of patients achieving PASI 90 and 92.6% achieving an IGA of 0 or 1 at week 16. And no new safety signals were identified across the entire phase 3 programme, although looking at the adverse event of special interest, we can see rates of fungal infections were high at over 11% in the initial period to week 16 and over 20% at the end of week 56. And there were no incidences of inflammatory bowel disease or adjudicated suicidal ideation or behaviour amongst patients treated with bimekizumab in Be Ready. Bimekizumab has also been investigated in a head-to-head study against ustekinumab, whereby 81.6% of bimekizumab treated patients achieved PASI 90 at week 52, compared to 55.8% of patients achieving ustekinumab at the licensed dose. And again, rates of fungal infections were higher at 14% for bimekizumab compared to just 0.6% for ustekinumab in the initial trial period out to 16 weeks, and 23.3% versus 2.5% for bimekizumab and ustekinumab respectively in the maintenance period out to 1 year. There were also more major adverse cardiovascular events in the bimekizumab group, although these occurred in patients with 2 or more pre-existing cardiovascular risk factors, which may have contributed to the events. In the Be Sure phase 3 randomised controlled trial, bimekizumab was investigated against adalimumab this time, and patients were randomised 1-1-1 to receive subcutaneous bimekizumab 320 mg every 4 weeks for 56 weeks, bimekizumab at a dose of 320 mg every 4 weeks for 16 weeks, then every 8 weeks from weeks 16 to 56, or subcutaneous adalimumab at a dose of 40 mg every 2 weeks for 24 weeks, followed by bimekizumab at a dose of 320 mg every 4 weeks to week 56. And the co-primary endpoints were PASI 90 and an IGA score of 0 or 1 at week 16. And at week 16, 86.2% of bimekizumab treated patients in both dose groups combined achieved PASI 90 compared to 47.2% of adalimumab treated patients. And in those who crossed over from adalimumab to bimekizumab at week 24, the same high response rates were observed as those who'd received bimekizumab from baseline. And as in the other trials, the most common adverse events with bimekizumab were upper respiratory tract infections, hypertension, diarrhea, and oral candidiasis, which was seen as at a rate of 16% in BE-SURE. And then finally, presented at the AAD last month, was BE-RADIANT, the phase 3b trial against secukinumab. So patients were randomised 1-to-1 to receive either bimekizumab 320 milligrams every 4 weeks or secukinumab 300 milligrams weekly to week 4, followed by every 4 weeks to week 48. And at week 16, patients receiving bimekizumab underwent re-randomisation in a 1-to-2 ratio to receive maintenance dosing every 4 weeks or every 8 weeks to week 48. And the primary endpoint in this trial was PASI 100 at week 16. At week 16, bimekizumab was shown to be non-inferior and superior to secukinumab. 61.7% of bimekizumab patients and 48.9% of secukinumab patients achieved PASI 100. And then at week 48, 67% of patients treated with bimekizumab had a PASI 100 response, as compared to 46.2% of those treated with secukinumab. And again, oral candidiasis occurred more often with bimekizumab at 19.3% compared to secukinumab at just 3%. A further recent network meta-analysis published in a German journal has also included bimekizumab alongside other biologic therapies for moderate to severe plaque psoriasis. And while the error bars are large, bimekizumab appears to be as efficacious compared to placebo as ixekizumab, and more so than infliximab, risankizumab and guselkumab. However, compared to placebo, the forest plot for tolerability suggests that bimekizumab has some of the greatest rates of adverse events, which in the most part is likely to be due to the high rates of candidiasis seen in clinical trials. So network meta-analyses such as these tend to focus on short-term endpoints, and we tend to look to registries for a longer-term real-world assessment and comparison of biologic therapies in psoriasis. However, I just want to finish off with these interesting data in Press by Loft et al., which report how early response to treatment with biologics might be important for the stability of psoriasis and long-term outcomes. The aim of the study was to assess whether risk of flares and drug survival are associated with disease activity in the first 6 months of treatment of psoriasis with biologics. Bio-naive individuals enrolled into the Derm Bioregistry were grouped based on absolute PASI during the first 6 months of treatment, as PASI equaling 0, PASI 0 to 2, PASI 2 to 4, and then PASI greater than 4. And we can see how the probability of flare-free survival was greater in those with the lowest absolute PASI scores after 6 months of treatment. And so from these real-world data, it does seem that a low PASI in the first 6 months of treatment with biologics in bio-naive patients with psoriasis may be associated with a more stable disease course, lower risk of flares, and longer drug survival. So that concludes our review of the therapeutic armamentarium for psoriasis. To summarise, we have reviewed the current stepwise approach to the management of psoriasis and considered some of the innovative approaches under investigation for the development of new topical treatments. We've heard clinical trial data presented at the recent AAD Congress for deucravacitinib, a novel oral TYK2 inhibitor, for apremilast in patients with mild to moderate psoriasis, and for bimekizumab, the new IL-17A and F monoclonal antibody, which has demonstrated superiority against adalimumab, ustekinumab and secukinumab in head-to-head trials. And then finally, we've taken a look at some of the more recent network meta-analyses and registry data which permit meaningful comparisons between therapies in terms of efficacy, tolerability and drug survival. I thank you for your attention.
Thank you very much, Laura. That was quite eloquent and crisply delivered with a lot of information. I'd like to, before we open up for discussion about your talk, ask again the previous question. For an obese patient with severe psoriasis, nail disease, and possible Achilles enthesitis, which of the following treatments would you choose after a patient has failed the conventional oral medications that we might use for treating psoriasis and what looks like incipient psoriatic arthritis. So please choose. Okay, so it looks like we still have a very similar percentage as what we spoke about before, i.e. a majority favoring an IL-17A inhibitor, and then a lesser percentage the IL-17 receptor antagonist, the IL-23p19 inhibitors, and IL-12/23 inhibitors, and a small percentage choosing Primilast. So this is interesting. We've seen the TNF inhibitors drop out of the race here in this case, and I think that's partly because we are seeing such remarkable skin effects with some of the newer agents that are in the IL-17/23 pathway, including brodalumab, which we don't have as much experience with in the US. So I would like to open up to a brief panel discussion before we move on to Michael Ward's presentation on axial SpA. Thank you very much. And Laura, that was fantastic. So Rodrigo, if I could turn to you first, do you want to make any comments about any particular aspects of your skin psoriasis, or was that, I'm curious, was that, if you think of an orchestra with different sections playing at different times, was the skin at one point, did it ever have a solo place? Obviously it did when you first developed the psoriasis and before you developed PSA. But once you developed PSA, what seemed to be a predominant issue in your mind? And
well,
being?
Sure. Thank you for the question. Thank you, Laura, for the presentation. And in my case, my psoriasis has always been mild, very mild, I would say. And I've been treated with topical medications like Coltar at that time and others. And so it never really bothered me that much as in comparison with PSA. So when I started to develop PSA, it was much worse for me, particularly. And when I started treatment, especially the biologicals, psoriasis, tended to disappear. Mm-hmm. I have a little bit now, but it's really, really mild in my case.
And can I ask you, Rodrigo, how have you found topical therapy? Has it been something that's been a pain, or is it something that you don't mind to use?
At the beginning, in the very beginning, I would say when I had very little information about the disease, I was feeling as I was being tested for different types of medications, and none of them seemed to be very effective in my case, even though my psoriasis was mild. And so it was a bit of a pain because it was, I was in the middle of something that wasn't working for me.
Mm-hmm. Yeah, and that's why I wanted to include topical therapies within the presentation, because we all get very excited about the new immunomodulators and the biologics, but actually topical therapy does still have a place for most patients. Even if they are on biologic therapy, they may still experience a flare if they've had emotional stress or they've had a recent infection. So it's exciting to see that finally we might be getting some newer and more efficacious and more tolerable treatments for patients. And I can't wait to get my hands on some of these new drugs.
It was interesting for me to hear, Laura, about your description of some of the medicines that aren't necessarily immunomodulatory, that are used topically to kind of prepare the skin, to prepare the plaque for better clearance. These are the kind of details and nuances that we rheumatologists don't know anything about. And so it's why it's so important for the for the patient to be in a shared derm room clinic, or to be where both clinicians can see the patient at the same time, or to have an easy shuttle back and forth and close communication with the patients. I was one specific question I had for you. I noted this slight paradox of in these meta-analyses of the IL-P19s coming out slightly higher than the IL-17s for the most part. ICSI was right up there, though, in terms of its effect in the skin, but it seemed to be different in the nails. Mm-hmm. Do you have any opinion about that?
Yeah, I suspect it's because we definitely consider nail disease and scalp disease to be a cutaneous biomarker for the development of PSA, and there is no denying that targeting IL-17 is probably a better treatment strategy for PSA, I think, than IL-23 inhibition. I don't know whether you'd agree with that. And I think it's that the two are intrinsically linked, that perhaps, and perhaps some underlying DIP arthritis or, flexitine synovitis. I don't know whether there's that integration, but we certainly see higher rates of nail disease in those with psoriatic arthritis. So I suspect that that's why. But yeah,
you don't think it's partly a phenomenon of the IL-17s working a little bit more quickly? Because we did see some data where you showed slightly quicker curves for the IL-17s compared to the IL-23s, but then the IL-23s coming along quite good in the end.
They do. And I think, that's something that a lot of the pharmaceutical companies will promote, and we'll talk about rapidity of response for the IL-17 inhibitors. But actually, if you break it down in those clinical trials, those head-to-head trials, in the Lilly one between ixekizumab and guselkumab, it was 2 weeks. That was the only difference, time to achieve PASI 90. And in Eclipse, it's around 10 days. So you have to sort of question how clinically meaningful that is for patients. And to me, durability of response is more important.
Sure, I understand. And boy, how we envy you for those head-to-head trials. Yeah. We look forward to a head-to-head in PSA between one of the IL-17s and one of the IL-23s.
Yeah.
Well, we're going to have more time shortly for a longer discussion. I've got more questions for you, including a little bit more on the Candida issue. But let's turn now, if we could, to our final presentation on axial spondyloarthritis by Michael Ward from the NIH in Washington, D.C. Starting with a question for a patient with axial SpA who has no comorbidities but has active disease but despite NSAID treatment, and whom you are considering escalating therapy, which treatment would you select next? So there you go. TNF inhibitor, IL-17 inhibitor, either one equally likely, a JAK inhibitor, or any of the three equally likely. I like the way Michael asked this question. We normally have some Bruce Springsteen or Jimi Hendrix in the background. I guess we're missing that today. Okay, so it looks like, either a TNF or a IL-17 inhibitor equally likely in 2/3 of the respondents. Almost 30% would select a TNF inhibitor, and then a small percentage in a JAK inhibitor. Okay, well, let's proceed on into hearing from Michael about current data and recommendations.
Hello, thanks for joining us. My topic for today is an update on the treatment of axial spondyloarthritis. The topics we'll cover are medications for signs and symptoms. We'll review the ACR treatment recommendations and go over how these contrast with the most recent ASOS-EULAR treatment recommendations, and then finish up with a few thoughts on disease modification in axial SPA. As far as the medications for signs and symptoms are concerned, these are the categories of drugs that are currently used. NSAIDs, of course, being the mainstays of therapy. Sulfasalazine, methotrexate, and corticosteroids really restricted to fairly specific special indications, primarily to treat patients with peripheral arthritis. And then, of course, moving on to biologics, TNF inhibitors and IL-17 inhibitors, and now more recently under investigation and becoming available, JAK inhibitors. One question that has been often asked is whether any particular NSAID is more effective at pain control than any other NSAID in patients with ankylosing spondylitis. In years past, we had always thought that indomethacin might have some special effectiveness. This is the result of a meta-analysis of short-term placebo-controlled trials of NSAIDs, with the outcome being change in mean pain scores over 2 to 8 week period of time. And in this network meta-analysis, we can see that atoracoxib actually is the NSAID that has the greatest pain improvement in pain relative to all of the other NSAIDs tested. Atoracoxib not available in the US, but in many locations it is available, and from my understanding, does have some preferential use among rheumatologists for treating axial SPA. Of the other commonly used NSAIDs, naproxen, meloxicam, diclofenac, celecoxib, all of similar effectiveness. So from that regard, unless you have atoracoxib available to you, there's no evidence to support preferential use of one NSAID over another. In clinical trials, and oftentimes now in clinical practice, we use the patient-reported outcome of the BOF-AS Disease Activity Index, which is a patient-reported measure of severity of these 6 symptoms, a 0 to 10 scale: fatigue, spinal or hip pain, peripheral joint pain or swelling, tenderness to touch, which tries to assess enthesitis, and then morning stiffness severity and duration. As far as the question of whether any particular TNF inhibitor is more effective than any other, this is, again, another network meta-analysis of controlled clinical trials of the efficacy of TNF on change in the BOSDI. So again, the 0 is where the placebo response is, and you can see that relative to placebo, all of the TNF inhibitors have comparable efficacy, maybe a little bit a relative improvement for infliximab or biosimilar infliximab on the bottom there, and that may relate to its IV mode of administration, perhaps giving a more prompt onset of action. In phase 3 trials of TNF inhibitors, the ASUS-20 response is the most commonly used primary outcome, and that involves a 20% or more improvement in 3 of 4 measures, along with an absolute improvement by 1 out of 10 in those 3 measures, and no worsening in the 4th measure. And the measures are all, again, patient-reported outcomes: patient global assessment, spine pain, morning stiffness, and physical functioning. If we look at the phase 3 controlled clinical trials of TNF inhibitors, you can see that their ASUS-20 responses all hover around 60%, compared to placebo responses, which were in the 20 to 30% range. If we consider what characteristics of patients may make them more likely to respond to TNF inhibition, this is the results of a meta-analysis of 33 studies, including trials and observational studies, that found that men, those with a higher BOSDI, those with an elevated CRP, and those who were HLA-B27 positive were more likely to respond to a TNF inhibitor, whereas older patients and those who had a higher functional impairment were somewhat less likely to have a good response. So something to keep in mind when you're thinking about trying to assess likelihood of response to treatment initiation in your patients. What about patients with non-radiographic axial SPA? This is a very nice meta-analysis of, again, controlled clinical trials that looked at change in BOSDI in non-radiographic axial SPA patients and in patients with radiographic axial SPA. And you can see here improvement in BOSDI, standardized mean difference of 0.73 in the non-radiographic group, standardized mean difference of 1.0 in the radiographic group. So while there is improvement with TNF inhibition, there may be slightly less improvement in the non-radiographic group than in the radiographic group. What about IL-17 inhibitors? A familiar sort of pattern of results from clinical trials. You see the secukinumab results here in blue, the ixekizumab results in green, and again, active treatment arms had approximately 60% response on the ASS20 measure, with placebo responses anywhere from 30 to 40%. Interestingly, in the ixekizumab trial, they separately enrolled and examined outcomes in TNF non-responders and also demonstrated improvement in that subgroup of patients. ASS40 responses averaging about 40% and placebo responses about 20% in these short-term clinical trials. And JAK inhibitors, again, very similar sort of graphs. Active treatment groups with about a 60% ASS20 response. Placebo responses here maybe a bit higher than the earlier trials, up to 40%, and comparable across tofacitinib, upadacitinib, and filgotinib. So again, short-term clinical trial responses for all of these classes of drugs, TNF inhibitors, IL-17 inhibitors, JAK inhibitors, with ASS20 responses in the 60% ballpark. Those clinical responses on patient-reported outcomes with upadacitinib have been sort of substantiated by comparable large changes in imaging measures of inflammation, both MRI in the spine and MRI of the sacroiliac joint, much greater improvement in radiographic measures of inflammation in the active treatment arms than in the placebo groups. If we look at ACR treatment recommendations, NSAIDs and physical therapy are the standards for new initial treatment of patients with active disease. Sulfasalazine and local glucocorticoids for patients with peripheral predominant disease that remains active despite NSAID treatment, and sulfasalazine was preferred over methotrexate. If disease remains active despite NSAIDs, the treatment recommendation is TNF inhibitors over IL-17 inhibitors or tofacitinib. There's no preferred TNF inhibitor with the exception of patients with recurrent uveitis or concomitant inflammatory bowel disease when TNF monoclonal antibodies are recommended. If people have active disease despite a trial of TNF inhibitor, the recommendation for the next course of treatment depends on whether they were a primary non-responder to the TNF inhibitor. In that case, an IL-17 inhibitor would be recommended, or if they were a secondary non-responder, meaning they had some response for some period of time that was then lost. In that situation, the recommendation would be to first try an alternative TNF inhibitor, thinking that they might have a response to an alternative agent in that class before switching classes of drug. As far as treatment of stable disease, the focus was really on how long do you continue treatment. If patients were on a biologic, the treatment was really against discontinuation of the biologic based on evidence that more likely than not the disease would recur, and against tapering, although tapering could be considered along with shared decision making with the patient if there was particular concern about the amount of medication that they were using. If the patient was treated with a biologic in addition to NSAIDs or a conventional DMARD, the recommendation was to stop the NSAIDs or the conventional DMARD first and continue with the biologic. As far as contrasting the ACR recommendations with the ASUS-EULAR recommendations, there are several differences. When starting biologics according to the ASUS-EULAR treatment recommendations, they really recommend only doing so in the cases where there's an elevated CRP or a positive MRI, or the patient has radiographic disease, as well as failure of courses of 2 NSAIDs, and high disease activity with some patient-reported measure or the OSDOS and the rheumatologist opinion. They also recommend a reassessment of treatment response at 12 weeks and recommend continuing the biologic only if the OSDOS has decreased by 1.1 or the BOSDI has improved by 2 out of 10 points. If there's failure of the first biologic, they recommend either a TNF inhibitor or an IL-17 inhibitor with no distinction between those two based on whether the person was a primary or secondary non-responder. And they endorse a philosophy, at least, of treat to target, although they don't really recommend any specific target. To finish up, we'll talk a little bit about disease modification. This is based on changes in spine radiographs measured by the MSAS, which looks at development of erosion, sclerosis, squaring, or syndesmophytes in the anterior corner of the spine, cervical and lumbar. A possible range of 0 to 72, scored on 12 vertebrae. And an increase of 1 point per year in this measure is taken to indicate progression. There are 3 studies that compared active treatment with etanercept to historical controls, and none of those studies demonstrated a lower mean change in MSAS over 2 years than historical controls, which are quite disappointing when these results initially came out. Subsequently, there was a study of celecoxib which showed that patients who used celecoxib on a daily basis had less radiographic change than patients who used it only on an as-needed basis. But this was not similarly confirmed in a study of diclofenac. And the question was, is this not telling us that there's a COX-2 selective effect on proliferative spinal disease in patients with axial SPA? The jury on that is still out. If we look at prospective cohort studies of TNF inhibitors as potential disease modifiers and look at, again, change in MSAS over a 2-year period of time, the pooled result of these particular series of studies suggests that there may be some suggestion of an improvement with less radiographic progression in people who used TNF inhibitors over those who were not treated with TNF inhibitors. The problem with many of these studies, again, there's a very long latency of effect. So starting a TNF inhibitor, you may not expect to see a change in your X-ray over 2 years, and that may require much longer duration studies. The MSAS itself is not terribly sensitive to change, It's driven by syndesmophyte formation, and new syndesmophytes are rare to detect over a 2-year period of time. And there's also the question of confounding by indication. Obviously, people who are treated with TNF inhibitors may have more active disease, and therefore may be those particularly prone to new syndesmophyte formation, sclerosis, and squaring. And so differentiating that disease activity from the treatment effect can be very difficult to do in observational studies. So there's tentative suggestion that TNF inhibitors may be disease modifying, but I would say the jury is still out. Thank you.
Thank you very much, Michael. And now let's return to our previous question. For a patient with axial SpA who has no comorbidities but has active disease despite NSAID treatment, and you want to escalate therapy, which treatment would you select? Okay, so it looks like there's a spread, and again, there's no right answer here. So about a third would choose a TNF inhibitor, 6% an IL-17 inhibitor, and equally likely a TNF or IL-17 inhibitor in the majority of attendees. Okay, so it looks like there is now increasing acceptance of the place of IL-17s in this treatment paradigm, and it'll be interesting how the JAKs are taken up. So I'd like to open up now to a general discussion. Thanks, Michael. Let's see, Rodrigo is here. I'm thinking Laura is going to join us as well. And so here we have a set of questions that I want to bring up. There you are, Laura. So the first one is I want to ask Michael this because I'm part of the steering committee, Michael, for the GRAPPA and ASAS study, which the AXIS study, in which we're going to be coming up with, or trying to come up with, a classification criteria for axial PSA. And as you can see in the presentations, there's controversy around this because of the fact that we're uncertain about whether the IL-23 class is going to work in axial PSA, if it's enough different immunobiologically from axial SpA or not to warrant it being effective there. And in the MAXIMIZE trial that Will Tillett showed, it turns out that MRI positivity was not part of the inclusion criteria. MRI was assessed on all of the patients, but not part of the inclusion criteria. It was up to the investigator to determine whether they had axial PSA or not. And then, as it turned out, 60% were MRI positive in the spine or sacroiliac joints, and 40% were not. So I'm really curious what your thoughts are about the MRI negative group of axial PSA patients and how to think about how to include them in an inclusion and classification criteria in the future.
But if I remember correctly, in the MAXIMIZE study, those who were MRI negative had similar proportions of response.
Exactly. That's exactly right.
Which is not what I think most people would have predicted.
Exactly.
From the AS or axial SPA point of view. Right. So my thinking is evolving, and I don't want to get too philosophical here late in the evening, but I'm coming to see that in addition to having these biologics help patients, which is what we're all about as our first priority, I think I'm becoming more appreciative of the fact that assessing responses to different drugs that target different biologics in different conditions are going to be telling us more about how to classify diseases than looking at it from a purely phenotypic standpoint. So I've been thinking about this quite a bit lately, and your question sort of relates to this exactly. Is instead of taking the traditional approach where we lump people together based on what their clinical phenotype is, maybe we should be stepping back and saying, okay, what does their biology tell us, and use treatment responses to infer their biology, and then group together subsets of patients with common biology, thinking that, well, even though they look very different from the outside, their disease is driven by the same pathway, so that we might think about targeting them with the next generation along that same pathway, rather than coming at them with another disease or another class of agents from a different class.
I love that response, and I love the fact that even though you and I are both of a certain age, we're learning something new every day. And we constantly are having to evolve in our thinking. But it also underlines the importance of development of biomarkers for better immunophenotyping these patients, which we're sorely lacking still in both PSA and XBA. I'd like to turn to Laura. And Samar Gupta has been an active person on chat. He was one who raised concerns about candidiasis with bimekizumab, and I'm going to be curious about your whether you share that concern or you think that's going to be a mild issue, but also the issue of the safety of the new TYK2 specific agent from BMS, the deucravacitinib. And I'll just jump in with one specific response, Samar, which is that in the POETIC program, there was a very low level of signal for VTE. What I mean by that, it wasn't completely absent, but it wasn't zero. It was not zero, but very, very small. And one of the cases, as I recall, was a patient who had some vascular instrumentation, if I'm not mistaken, and there was another patient who had really significant cardiovascular risk. And so I think the answer is going to remain in the future. We're optimistic that being so specific in its TYK2 specificity may yield some benefits in terms of safety in the long run compared to some of the other members of the JAK inhibitor class. But we really need to see more data in that regard. And what I'm reminded of is the journey we had with tofacitinib. So I was involved in some studies that looked at all of the trials in all of the indications for tofacitinib, and a analysis of the tofacitinib versus TNF inhibitor use in the large corona registry, more than 40,000 RA patients in the US, and then the Truven database, a big population database. And when all of that was looked at, it did not appear that there was any VTE signal, any thromboembolism signal with tofacitinib. Then oral surveillance came out, and that upended our thinking about that, where this was a really high-risk group of patients that were enrolled in that study purposely to sort of challenge them. And that's where the higher dose form of tofacitinib showed some signal compared to the standard dose or TNF inhibitor class. So I think that we really are going to need more observation over time to really tell about the answer to this particular question. Sorry to take so long in answering that, but I think you have to put it in context. Turn it over to you, Laura, in terms of your thoughts on Ducra and its relative safety and whether it's going to be an apremilast but maybe more efficacious.
Yeah, so I think as dermatologists, we are perhaps quite twitched by this concern of a VTE because, of course, we just have received baricitinib, so the first JAK inhibitor for use in dermatology, which we're now using obviously for atopic dermatitis, and that's one of the key things that we are making sure that we sort of assess for and screen for in our patients. So I can understand why there is that concern about TYK2 being in the same molecular pathway. But I think you hit the nail on the head in what you said about it being more specific. So rather than, blockade across the entire JAK system, I think, but time will tell. But certainly in the trials and the sort of limited data that we've seen so far for Poetic, I think it was just reported as being low and consistent with apremilast. I'm hopeful that efficacy will be greater than apremilast. It certainly seemed it in the trial. I don't think it's going to be the blockbuster drug, and I think it's going to be that argument again that is this more suited to those patients with the moderate severity disease rather than, trying to compete against the biologics. But, again, apremilast has its place, particularly in patients where we have comorbid concerns about using biologic therapy. So, again, hopefully maybe that's where deucravacitinib will find its place. And then I think you mentioned as well about bimekizumab and candidiasis. Was that one of the
questions? Yes, that's been in a couple of questions about that.
Yeah,
yes.
I know. So we did see those high rates, didn't we? And, we know that IL-17 plays that pivotal role in regulating antifungal immunity through upregulating, pro-inflammatory cytokines like IL-6 and, the antimicrobial peptides like the defensins, and they act obviously in concert to try and limit microbial colonization in barrier tissues such as the skin and the gut. And because of the drugs targeting IL-17, they're blocking all sources of IL-17, not just that's produced by Th17 cells in the adaptive immune system, also innate T17 cells, things like gamma delta T cells. So, that protection from opportunistic fungal pathogens is greatly reduced. For me, at the moment, it's not clear if it's specifically this additional F isoform of IL-17 that's perhaps more fundamental to this protective role than IL-17A, or whether it's, we're seeing those high rates of candidiasis are just more representative of the more sort of profound blockade of IL-17 overall. But then you could argue that with brodalumab, you're blocking the receptor, you're blocking more isoforms, and we're not quite seeing the same degree of candidiasis that we're seeing in the clinical trials for bimekizumab. So again, I think it's going to be one of these things that we see how it plays out. We do see it for ixekizumab and for secukinumab, but to a tolerable level. The company, I think, are quite worried about how people will perceive the clinical trial data for candidiasis, and whether people will be worried that will put them off. But I think it's just going to take some real world experience using this drug to determine how sort of impactful that is. I mean, Rodrigo, would you be concerned if I offered you a drug that had reasonably high rates of candidiasis?
Well, I think it would depend on my condition and how bad I'm feeling with the disease to take some risks. Yeah.
I mean, it's high rates of efficacy. It's a great drug, certainly for the skin, but it could have an impact.
I think just to say one quick comment there, it's important for everyone listening to know that the manifestations were generally mild to moderate. Yeah. And your use of the word tolerable is very important, because some patients, if they get great efficacy, will tolerate certain side effects. And in some of my patients that have developed Candida thrush or vaginal, that it can be treated, but they can continue treating with their underlying treatment. And Rodrigo, you had a question that I know that you had asked if you could ask the group.
Yeah, if we can. It's a simple question, and whoever wants to answer it, I'm happy. I mean, it's very interesting to see the variety of very promising drugs and treatments, and with such a variety of possibilities, I mean, and with different responses for skin and joints conditions, how is the process of deciding the best treatment in case where realms and derms aren't a part of the same team, or when we don't have a kind of holistic approach to the patient? Well, the reason for this question is that in conversations among us, patients, there's the feeling that in general, the impact of skin seems to be underestimated, but I'm not sure. I'm just feeling.
Biased rheumatologist? No, we pay total attention to the skin. Are you kidding me, Rodrigo? That's the first thing we ask about when we walk in the room. Isn't it, Michael?
Well, I always say if we didn't have musculoskeletal system, it would all be coral. So, what system needs to be predominant?
I hold my hands up and I agree. If there is a tussle between me and my rheumatologist and I'm trying to push for a 23 inhibitor, say, and they want to use a TNF, and, there's this back and forth, time is bone. And actually, if PSA is the predominant issue for that patient, I will be led by getting control of the joint. But again, similarly, I will still advocate for my patient for the psoriasis side of things, because as you said, that profound impact, it's visual. You look at it every day in the mirror and, only you know how it makes you feel. PSA can be hidden, whereas it's very visual. So it has to be that collaborative approach and that joined up thinking. So I fully agree, Rodrigo.
Well, it comes back to you, Rodrigo. You have to be the advocate in that room for yourself and for the symptoms you're experiencing, and be sensitive to the fact that the clinician may not be focusing on some of the things that are important to you. And so you need to have the courage to come out and really be clear about what's important to you.
Well, yeah, it's interesting to see the arguments, and and I think for patients it's always an issue in terms of the skin, especially because there is the appearance issue. Sometimes there is a difficulty of speaking ourselves in terms of how we feel about our skin, for example, and sometimes the lesions are in intimate parts of our bodies, and we don't feel very open to talk about it.
But we should ask. We know that it can affect the genitals. We know that it can affect hidden areas, so we should ask.
Right. Well, this has been a fantastic discussion. I wish it could keep going on. I feel like I've got tons of questions for all of you, but we need to be respectful of the hour of the day for various members of our attendee audience who are in different parts of the world. We really do appreciate your attending. We want to very much thank the support that we've gotten from the organization Nucleus that's been producing this for us. We'd like to thank particularly our administrators, Lisa Spiegel and Janine Kowak from Spartan and Grappa, respectively, who have helped get us through all this. And we want to particularly thank Pfizer. Pfizer is very generous in providing this unrestricted grant to do these educational programs. Please be sure to complete the survey at the end of the program. It's important for us to get understanding about what we are doing well or not well, and as we go forward into continuing seminars in the future. And specifically about that, we have a further module that we will had intended to present later this summer, but we're going to be moving that into the fall as part of a ongoing series of these seminars, and that will include some discussion about pediatric rheumatology and dermatology. So again, thank you very much for taking the time to learn about psoriasis, psoriatic arthritis, and axial spondyloarthritis, and participate with us in this journey.